This is going to be my respiratory emergency patient assessment, and we're going to get a dispatch call that called to a home for a man having trouble breathing with chest pain. And we're going to take or verbalize the body substance isolation precautions, so BSI, and scene safe. We're going to determine the MOI or the NOI, and in this case it's going to be a respiratory. Number of patients, we're going to have one patient, and we're going to request additional help if necessary, and in this scenario we're going to request ALS. We're not going to consider the immobilization of C-spine, and then we're going to go to our general impression, and we're going to have a 44-year-old patient sitting in a tripod position at a picnic table having respiratory distress using his accessory muscles. And then we're going to determine responsiveness or the level of consciousness, and he's going to be responsive, alert, and oriented. The chief complaint, difficulty breathing with chest pain, and then the airway is open because he's breathing, but it's a noisy breathing, and so we're going to assess the airway and the breathing. It's a labored rate. We're going to indicate appropriate oxygen therapy, so there's a symmetrical rise and fall of the chest, and we're going to give oxygen via a non-rebreather mask at 15 liters per minute. Then we're going to go into circulation, and there's no bleeding, and we're going to assess the controls and the major bleeding. So the pulse, we're going to see tachycardia, and it's going to be strong. Then we're going to assess the skin color, the temp, the condition, and it's pale with cyanosis around the earlobes. We're going to identify this patient as a priority because a field assessment is pretty much going to show that it's a congenital heart failure. And then we're going to go into the OPQRST. The onset, he was sitting in the home. Provocation, laying down makes the breathing worse. Quality, he has a slight chest pain, but kind of like a sharp stabbing. Radiation, none really. And then time, approximately an hour, but he's been sick for a few days. Then we're going to go get a sample history. We kind of already got the signs and symptoms. Allergies, nope. Medications, I'm going to say he's taking a Lasix and a potassium. And then past pertinent medical history. He's going to have water in the lungs, so like pneumonia. And last oral intake, probably lunch. And the events leading up, he's just sitting there. And we're going to go into and we're going to perform a secondary assessment, and we're going to palpate the chest, and we're going to listen to the heart and breathing. And the lungs, we're going to listen to up to the midsection, and we're seeing a slight JVD with a pedal edema. So we're going to go into the vitals, and we're going to just take the baseline vitals, and we're going to blood pressure, say 160 over 100 mmHg. His pulse is about 120 beats per minute. Respirations around 26 breaths per minute, and oxygen saturation or about 88%. As I said before, this is probably going to be a congestive heart failure, and that's going to be our impression. And about the only interventions we can do as an EMT is going to be the oxygen via the non-rebreather mask at 15 liters per minute. And we're kind of loosen up his clothing and work towards getting him to the hospital as soon as we can. Yeah, on our way to the hospital, we're going to keep our ongoing assessment, and the mental status is going to remain unchanged. The patient's probably going to get tired, and he's using more accessory muscles. His heart's failing. The blood pressure is probably going to continue to increase a little bit because it's going to have to work harder. The pulse is probably going to stay around the same, and the respirations are probably going to increase because he's trapping all that carbon dioxide. Then once we get to the hospital, we're going to hand off to someone or equal of higher status, and we're just going to provide the handoff report from the info above.